I'm Ronald Washburn, and we can get started now. I'm one of the infectious disease docs, and I'm based primarily at the VA. I've known some of you for years. Maybe there are a couple in the back that I don't know, but I was trained as a clinical mycologist during fellowship, and so every once in a while, when it's my turn to do grand rounds, I like to go back to my roots and talk about some of those types of things. And one caveat is I was really relieved as an ID fellow to go into clinical mycology because there was really only one effective antifungal drug that we had at that time. It was amphotericin or nothing, so it was kind of like a binary decision that we had to make in terms of treatment, and that was just perfect for a person like me who doesn't deal with complexities all that well. But now the complexities have been thrust upon me, so what I'm going to do is give you kind of a brief history of the evolution of antifungal drugs, starting with the dinosaur, Amphotericin B, and coming through the present time. And along the way, we'll talk a little bit about mechanisms, but hopefully not enough to be boring, only insofar as the mechanisms are relevant for understanding the relation with the fungal target particle. And then more importantly, we'll talk about the spectrum of activity for the major antifungal drugs and some of the limitations of the drugs, such as side effects and drug interactions. And then in the final topic, I'll briefly touch on the fact that, of course, there is emerging resistance to antifungal drugs, particularly the azole agents, which will become a challenge going forward. And fortunately, there is some activity out there in the pharmaceutical industry that's already targeting this problem, and I'll briefly mention that towards the end. So let's start with amphotericin B. Several of us in the room were born actually before there was a single effective antifungal drug in the world, and so if any of us would have come down with cryptococcal meningitis or disseminated histoplasmosis before 1959, we wouldn't be here with you right now. But amphotericin B was marketed in 1959 and, of course, is a very effective and still probably the broadest spectrum antifungal agent we have. Just as a reference point, this is what Chevrolets were looking like back in those days, and I heard one comment from one of my colleagues before grand rounds to the effect that there was one of these in his family and there was one in my family too. The second antifungal drug with good systemic activity to be marketed was 5-FC, or flucytosine. This happened in 1972, and by that time the Chevys had evolved into this type of appearance, and this handsome dog was President of the United States. Those were the days. Next to come along were the azoles, shortly after 1972. And the first two out were Miconazole and Ketoconazole, which aren't used that much these days, but they're the ancestors of the modern agents such as Fluconazole and Itraconazole and Cresemba that we're using now. The next major milestone was the marketing of Caspofungin in 2001. That was the first marketed Echinocandin. And of course, it had some advantages over previous agents that we'll talk about. And so now it's time to talk about the structure of the fungal target particle because of its relevance for understanding how the antifungal drugs work. So here we have the eukaryotic cell and its intracellular organelles. And on the right, we have a blow-up of the barrier between the cell and the external environment. So on the outermost layer is the layer of manoproteins. To my knowledge, these are not yet targeted by any of the antifungal drugs, but they're there, and since they're surface components, they're important antigens. Immediately beneath that layer is the glucan layer, which is the major structural component of the cell wall. Very sturdy and comprised of beta-1,3 and beta-1,6 glucan. The relevance of this is that we have now an inhibitor of the beta-1,3 beta-glucan synthase, which is the echinocandins, and as we'll see in subsequent slides, exposure of fungal target particles to the echinocandins leads to weakened cell wall structures and cell death. Beneath that is the chitin layer. This layer really hasn't been as well exploited as an antifungal target, and I'll not mention the name nicomycin again ever in this talk, but I'll mention it right now just so that you're aware that there is a chitin synthase inhibitor called nicomycin that's in development for the past few decades, and obviously has gotten off to a slow start, some of which is based on the financial health of the sponsors that have been sequentially trying to develop it. So it may be a long time before you hear that word again. However, another major antifungal target, obviously, is the most internal of the layers. That's the cell membrane. Mammalian cell membranes, of course, have cholesterol as their major sterol component, but fungi instead have ergosterol, and this is relevant because we have an inhibitor of the ergosterol synthesis pathway, and that is the class called imidazoles that inhibit an enzyme on this pathway called linosterol demethylase. And also, amphotericin is said to intercalate amongst ergosterol molecules, and I'll show that slide in a few minutes. Finally, the cells have to reproduce their own DNA and RNA and do protein synthesis like all eukaryotic cells, and so these are additional targets for antifungal therapy. It's 5-FC that targets these elements. So that's the overview, but let's drill down on the components now and talk a little bit about the various classes one by one. First, conventional amphotericin B deoxycholate, not one of the lipid preps like Ambisome or Abelset, but old-fashioned amphotericin B deoxycholate. Not used as much anymore these days because we have less toxic alternatives, but I'll still talk about this because the active component of all those lipid preparations is amphotericin B, basically. So what's the mechanism? It's to actually insert itself into the fungal cell membrane. It binds to ergosterol and thereby makes the membrane leaky, shown here. Makes the membrane permeable so it leaks intracellular components such as cations and proteins, and that's how the drug kills fungi. This slide shows the amphiphilic structure of the molecule with a major hydrophilic chain and a hydrophobic chain. And it's said to be the hydrophobic chain that intercalates into the cell membrane, but both chains contribute to membrane leakiness. And that's shown here. So here we have the lipid bilayer with the ergosterol molecules and the amphotericin coming into play. intercalating into the cell membrane, creating these leaky channels that kill the fungus. So this is like a sawed-off shotgun approach to antifungal therapy. This drug is effective against most fungi that are known to cause human infections, with rare exceptions like Aspergillus terreus, for example. And that's mentioned in this next bullet point. We do have a handful of fungi that are somewhat frequently encountered as invaders of human tissue that are actually resistant to amphotericin B, and so when we're dealing with these patients, we have to look for alternative antifungal therapy. The drug is insoluble in water, but is in suspension as the deoxycholate preparation. And then in humans, the amphotericin molecule separates from deoxycholate and becomes bound to serum proteins. The drug is stored in the liver and re-enters the circulation very slowly. And this is kind of an interesting point. This phenomenon leads to a long beta phase of drug elimination in the human body. And I think we'll come to a slide in a few minutes that shows that after a patient has had a full course of amphotericin B, the drug keeps on being released from the liver for a significant period of time afterwards. The drug penetrates poorly into inflamed meninges and yet is effective against several forms of fungal meningitis, such as cryptococcal meningitis. What about metabolism or degradation? The drug is slowly degraded in tissues not affected by liver or kidney failure. And here's the thing about the biphasic elimination. There's an initial half-life of 24 hours followed by a second half-life of 15 days after the final dose of the drug. So this leads to some extended antifungal therapy after a course of amphotericin. And then there are some studies out there that show that actually the drug is detectable in serum up to 7 weeks after the end of therapy. The side effects are one of the major limitations, and probably most of us are familiar with these. With the first few doses especially, the drug can cause acute reactions like chills and fever, but then those reactions tend to become milder with subsequent doses, and that phenomenon is called tachyphylaxis. And we can somewhat blunt these reactions by pre-medicating the patient with acetaminophen. But a few of them will go ahead and have a chill during the infusion anyway, and most of those will respond very well to 25 milligrams of Demerol given parenterally. So this is usually what we recommend, is pre-medicate with acetaminophen, often with a low dose of Benadryl, and if that's not enough, then give them a squirt of Demerol, and that should make them comfortable. But then a few people really are refractory to all of this, and those are the ones that we reserve this recommendation for. Those people, we should be able to get control of their immediate type reactions by adding 25 milligrams of hydrocortisone to the amphotericin bag itself. The medicines are compatible, so that's a good way to do it. The longer-term toxicity, the main one is nephrotoxicity, which is a dose-dependent decrease in the glomerular filtration rate, and the mechanism is known to be primarily by a vasoconstrictive effect on the afferent renal arterioles, which leads to wasting of primarily magnesium and potassium. So many of us in the room have had the experience of chasing these ion levels during courses of amphotericin therapy by replacing those things. And after a few weeks, we get decreased erythropoietin production and anemia, and sometimes need to transfuse the patient. This slide just makes the point that if we have a patient that really feels terrible after every amphotericin injection, what we can do to help them is to double the dose on alternative days, and that way at least every other day they feel good at breakfast time and are able to eat. They can have a slightly better quality of life that way. There are a couple of studies that have shown a nephroprotective effect of saline loading patients prior to the amphotericin infusion. And what most people do is give 500 cc's of normal saline rapidly, like over an hour, if the patient's heart function can tolerate that, and then give the Ampho immediately after it. And I've used this some, haven't kept numbers, but I'm convinced that it's helpful. This slide talks about the formulations of amphotericin that are now more familiar to most people. We're able to prescribe both of these fairly readily over at the VA now. I know at one time when I was doing consults here, the pharmacy was pretty strict about wanting Abelset to be their formulary agent, and I don't know if that's changed. But be that as it may, they are both effective lipid preparations of amphotericin that are less nephrotoxic and useful for that reason. The colloidal dispersions have never really taken on as much use as the other two, and part of this may be a bad reputation that came from some acute pulmonary side effects that these preparations had. I can't remember the details, but some, I think, acute hypoxia during infusions. So Ambisome is worth focusing on for just a minute because there's a pretty solid evidence base for two fungal infections that I know of, established with comparative trials. Ambisome versus Fungizone, which is the commercial name for the deoxycholate preparation, that showed a significant therapeutic edge for Ambisome over Fungizone. And those are cryptomeningitis in AIDS patients and disseminated histoplasmosis in AIDS patients. And you can see the response rates here. So those recommendations are in the IDSA guidelines. Next, we can shift gears and talk about another old antifungal drug. 5-fluorocytosine. This is a fluorine analog of cytosine, which of course is a mammalian compound, moderately soluble in water, rapidly absorbed through the GI tract, excreted 90% unchanged in the urine, which for some purposes is useful, but as a practical matter, it means that we have to be careful in patients with any degree of renal insufficiency because the drug is cleared renally. And so when we're giving a combination of amphotericin plus 5-FC, for example, in a crypto patient, or sometimes we do it with invasive candidiasis patients, we're dealing with a moving target, which is a creatinine, which is creeping up secondary to the amphotericin use, and an essential second antifungal therapy that's cleared renally. And so for that reason, it's recommended that we monitor renal function and 5-FC levels closely in patients like that. Because if we don't, then we can see flucytosine-related side effects, which I'll talk about in a minute. The drug is only minimally protein bound. It gets into the spinal fluid, great gangbusters. And there's now an older cryptococcal meningitis study that compared amphotericin monotherapy at 1 dose to lower dose amphotericin plus 5-FC. And the 5-FC arm performed very well in that study. And so combination therapy has been found within the guidelines for many years now, something like 30 years. It's one approach we can take to treating cryptomeningitis if we have a patient who can tolerate 5-FC. The mechanism, without going into too much detail, is inhibition of thymidylate synthetase, which interferes with fungal DNA synthesis, and then further metabolism disrupts fungal RNA synthesis and protein as well. So that's shown here. The drug comes in to the fungal target particle through the cytosine permease. If we have a decrease in the amount of permease in the membrane or a mutant permease, then we may have a 5-FC resistant organism, however. Comes in and goes through this metabolic process that leads to inhibition of DNA and RNA and protein synthesis within the fungus. Also important to mention, gee, that seems like kind of a neat mechanism, and why don't we try using it as monotherapy against some fungal infections? The reason for that is it was tried that way initially when it was first marketed, and it turned out that both in the case of cryptococcosis and candidiasis, there was rapid emergence of resistance to 5-FC monotherapy. So it typically has to be used in combination with another antifungal drug. That's shown here. What about the spectrum of activity? It's active against most Candida species, except for Candida krusei. It's active against most isolates of Cryptococcus neoformans. It also has a special niche in treatment of melanin pigmented molds, the ones that cause chromoblastomycosis, like Cladophyalophora. It's kind of an esoteric little corner for it to live in, but it's very useful in that world. The dosage, really probably the better thing to say these days because of the large studies that have been done in AIDS patients with cryptococcal meningitis. The ideal dosage is 100 milligrams per kilogram per day in 4 divided doses, so 25 milligrams per kilogram each time. If you dose at that level in a patient with normal renal function, it's unlikely that you're going to see 5-FC toxicity, which can be significant. Then here's the blurb about monitoring the drug closely in patients with renal insufficiency. And again, we're supposed to monitor blood levels of this drug because when we get levels of greater than 100 micrograms per mil is when we'll start to see toxicity. So the ideal level is 20 to 100, or in updating myself for this lecture, I saw that the more recent number is actually 20 to 50 is the ideal blood concentration of 5-FC. The side effects to watch out for, number one, diarrhea. Not often seen unless the drug is starting to accumulate to those higher serum levels. People speculate that the mechanism of that diarrhea is metabolism of 5-FC into 5-FU in the gut, probably with the assistance of gut bacteria. The end result being what's known for a fact is if patients accumulate the drug that they can get a pretty destructive form of colitis with mucosal ulcerations. Hepatic dysfunction is less common, and the drug can have really significant bone marrow toxicity if the drug levels accumulate. That's all I was going to say about 5-FC. So now we can move on to the azole antifungal agents. Fluconazole and Itraconazole probably being the best known prototypes these days. It's the imidazole ring itself that confers antifungal activity. And the way these agents work is to bind to the fungal cytochrome P450 enzyme C14 alpha linosterol demethylase. That's on that ergosterol synthesis pathway. So the end result is a decrease in normal ergosterol synthesis, which leads to abnormal leaky membranes depicted here. So here comes the azole targeting the fungal cell membrane and leading to accumulation of toxic sterols within the membrane and an unhealthy fungal target particle. Echinocandins was the first oral imidazole that was available. It's out of the limelight now, and one of the major reasons is that unlike the more modern azole drugs, it cross-reacts a good bit with the mammalian P450 system. And so based on that, we get some endocrine side effects from ketoconazole, and the endocrinologists have exploited that effect. So in mammals, because of this, we see decreased synthesis of testosterone. It was fairly common when we had to give longer courses of ketoconazole to males to see gynecomastia after a month or two of therapy. And the drug also inhibits glucocorticoid synthesis because of this same mechanism. And it's that effect that was exploited by the endocrinologists. The drug has been used successfully to control Cushing's syndrome, or at least it's in the armamentarium. It's the end substitution of imidazoles that leads to the triazole class that is equally effective as antifungal agents, but less effect on human sterol synthesis. So now we're talking about the ones we are all working with now: Fluconazole, Itraconazole, Cresemba, among them. Triazole, by adding that extra nitrogen in the ring, the drug became more specific for the fungal P450 system. First, we can talk about Itraconazole. Itraconazole is a very useful drug in certain situations, which I think I'm going to list a few slides down the road here. But it also has some limitations. One of which is it depends very much on some gastric acidity for absorption through the GI tract. And so we have to look to see if our patients are taking PPIs, and we have to ask them if they're taking over-the-counter H2 blockers, which a lot of people do love, chewable pepsids. If we can, eliminate those drugs in order to facilitate absorption of itraconazole into the bloodstream. Another trick that we play is to have the patient swallow the medication with Coca-Cola, which has a pH of about 1 and is very helpful. This drug is metabolized by the liver and excreted as metabolites in the feces. This is the very significant list of clinical activity for itraconazole. It's the drug of choice for most cases of blastomycosis and histoplasmosis, unless those patients have life-threatening presentations that would require an amphotericin product. South American blastomycosis, which is paracoccidioidomycosis, sporotrichosis, cocci. It's useful in non-meningeal forms of cocci. For meningeal forms, we need to use fluconazole. And pheohyphomycosis, which is another one of these syndromes caused by pigmented fungi, which kind of overlaps with chromoblastomycosis, but that's a long story. Itraconazole is also on the list of effective therapies for onychomycosis alongside terbinafine and fluconazole, and it's active against tinea versicolor, the causative organism being Malassezia. It's very much to do with the liver. Its major side effect could be hepatotoxicity, and it's something that has to be monitored during therapy. That's one caveat. Another is that the oral suspension contains cyclodextrin, which that compound can produce nausea and diarrhea. And the final bullet just talks about the specificity in comparison to ketoconazole. We're not going to see significant endocrine side effects from itraconazole. Drug interactions, of course, are always a consideration with P450 compounds. And so that's what some of these drug interactions down here are about. Rifampin, rifabutin, INH, and dilantin all decrease itraconazole blood levels, whereas itraconazole itself increases the blood levels of several other drugs that our patients may be on, as listed. And the top bullet we really already touched on, that is, we need some gastric acidity in order to absorb the drug. So that one was highly protein bound, likes gastric acidity. I forgot to mention it likes a fatty meal. It gets absorbed better with bacon. Fluconazole doesn't care about any of those things. It's relatively non-protein bound. It's very water soluble. It doesn't care about gastric acidity, and you don't have to eat a fatty meal to get absorption through the GI tract. It's probably the most bioavailable of all of the useful antifungal drugs. So everywhere there's water, you're going to find it in the human body, including the CSF. It gets great CSF penetration. The majority of the drug appears unchanged in the urine, and of course that's very useful. We can treat some flavors of Candida urinary tract infections because of that. The major indications for fluconazole use include candidiasis, cryptomeningitis, and coccidioidomycosis. That's a very general statement, and I don't want to oversimplify. It would depend on your particular case as to whether primary fluconazole may be appropriate for your patient. But for example, it's acceptable therapy as primary coverage for candidemia, even though the Echinocandins are listed as the preferred therapy. And it's effective for all but the most life-threatening forms of coccidioidomycosis. Side effects, fairly common: headache, anorexia, a little bit of nausea, reversible hair loss with prolonged use, maybe a little bump in the transaminases, and drug interactions that are similar to those with itraconazole. Voriconazole, like fluconazole, is available in IV and oral preparations, whereas itraconazole was available only as an oral preparation. And Vori is a very useful drug that has some limitations. So one is that the IV form comes in a cyclodextrin vehicle, again, like the oral suspension of itraconazole. And the problem with this in the IV form is that the drug is then contraindicated in patients with significant renal insufficiency, and it's kind of a moderate cutoff. As I recall, it's contraindicated with a GFR of around 50. It's cleared by the liver. Oh yeah, here's the creatinine clearance. Can't use it in less than 50. Voriconazole is first-line therapy for invasive aspergillosis, either proven or probable. It was a good quality multi-center comparative trial that showed its advantages over amphotericin B early in this century. This is a well accepted fact. It also is first-line therapy for some less common invasive fungal infections, including fusariosis and pseudoalischiriosis. Side effects, a lot of people get transient visual blurring for about an hour after the dose. And it's good to warn people up front that they might get that because it's not as scary if they know it's coming. And say that same thing about visual hallucinations. I met a patient once who had this, and his hallucinations were kind of funny, and I can't repeat in front of this audience what they were, but they weren't unpleasant to him, but they can be scary. And what my former colleagues at the NIH discovered was, when they got called into the room of a patient who was hallucinating from a voriconazole injection, if they would explain it's only a hallucination, the patient could appreciate that information, then they would relax. They would know it wasn't real. That came out as a paper in Clinical Infectious Diseases about 10 years ago. Drug interactions similar to Itraconazole, and Voriconazole decreases the clearance of omeprazole, so I guess that would decrease your omeprazole requirement if you were needing that drug. Just a couple words about two azoles that I'm aware of that have activity against mucormycosis. That's what I chose to emphasize here because from a practical point of view, otherwise these drugs, to my mind, have little to offer in terms of advantages over, let's say, Voriconazole. But one would be that they're active against mucormycosis and Vori isn't. And for that reason, it always makes me nervous, or usually makes me nervous, when I see Vori or Fluconazole being used in a neutropenic patient with fever, because there's one major pathogen that behaves just like Aspergillus that Vori will have no activity against, and neither will Fluconazole. I'm much more comfortable if we have to give those patients an azole instead of amphotericin to see them getting either posaconazole by mouth if they're not that sick, because posa comes only as an oral preparation, or Cresemba, which can even be given IV. But otherwise, from a therapeutic point of view, Cresemba is the same thing as posaconazole, except for the fact that it's available both IV and PO. What about disadvantages of this class of agents? We've talked about some advantages. One major problem is emerging resistance. So much so that I'm sure, for example, pretty much all of us in the room are aware that Candida glabrata and Candida krusei are routinely clinically resistant to Fluconazole. And the amount of resistance over time in the community continues to go up through the years. The bug has multiple options to develop resistance. One would be just to crank up a drug efflux pump that's going to spit the drug back out. Another would be to either alter or elevate the C14 alpha demethylase activity. In other words, you might be able to saturate the drug if you're a fungus by just increasing your enzyme production, the target enzyme production. That's pretty much what we're saying at the bottom of that slide. Now we can switch gears and talk for a few minutes about echinocandins, the newest kids on the block. These drugs were the first to target the cell wall. The others were mainly targeting the cell membrane. These drugs inhibit the beta-1,3-D-glucan synthase, which leads to the glucan component of the cell wall. And I'll show some micrographs in a minute that show the structures of fungi that have been exposed to these drugs. They're weird looking. To my knowledge, there are three major licensed echinocandins. They are Caspofungin, which was the first out, Mycofungin, and Anigulafungin. And these three drugs are therapeutically equivalent to one another. There's not much to choose between them. They're very large molecules. It's a lipopeptide structure. This schematic just shows the development of weakened cell walls in the presence of the glucan synthase inhibitor. The spectrum is similar among the three licensed drugs. But the major point here is that there are two species of Candida that tend to be resistant to the echinocandins in vitro. And it's something to watch out for a little bit. How do you handle something like this? I mean, we had a case a few months ago at the VA of a patient who was in the ICU and was a poster boy for having all the risk factors for candidemia. Catheters coming out of every orifice, had been on broad spectrum antibiotics and having diarrhea and maybe a shot or two of steroids. And then he develops a fever and he gets blood cultured, and the first info that comes back is that he's got yeast in his blood. And so we all know that the therapy of choice for candidemia nowadays is an echinocandin. So we got started on Mycofungin. But then several days later, when the bug was speciated, it turned out to be Candida parasilosis. What do we do about that? Well, we can look back in the studies that compared, for example, Caspofungin to amphotericin, and see that there was a handful of patients in those studies that turned out to have Candida parasilosis fungemia who developed negative blood cultures and clinically did fine on echinocandins, even though there was the theoretical concern about in vitro resistance. And so that was the story with our VA patient. The patient had already cleared the candidemia by the time we discovered the species was parasilosis. And so we continued on our merry way with the least toxic antifungal drug we could give the patient. And less people know this point. The drug is actually approved based on a small open study for treatment of invasive aspergillosis in patients who have either failed prior anti-aspergillus therapy or they're intolerant of all of it. And I know Dr. Mata and I salvaged one patient with this approach over at the VA. So this slide shows normal Aspergillus hyphae in the absence of echinocandin, and then over time in the presence of echinocandin leading, these are not yeast cells because this is not Candida. This is Aspergillus, which shouldn't have any spherical structures like this, and this type of culture grown under these conditions. What this is weakened cell walls that are bulging out. That's like diverticuli getting ready to pop, basically. The indications for echinocandins, the main one is candidiasis. I've said most of this already, and also for the invasive aspergillosis patients that need to be salvaged. This agent is not renally excreted. So that's not a concern at all in a renal failure patient. However, in moderate hepatic insufficiency, it's recommended that we decrease the daily dose from 50 to 35 milligrams. There's a handful of drug interactions, some of which involve cyclosporin, others of which involve tacrolimus or rifampin. And so I don't actually have a slide about the problem of antifungal drug resistance beyond what I've said already, but I'll just say it. We now have an issue that's emerging as more and more of a problem, which is Voriconazole resistance in Aspergillus species. It's a significant problem because Vori is first-line therapy for Aspergillus nowadays. But if we have a patient that's not responding, we may want to send their isolate for some antifungal susceptibility testing. And so that's why I'm interested in this new class of antifungals that's being developed by a little company in Liverpool, England, called the Orotomides, which target the pyrimidine biosynthesis pathway, again, similar to 5-FC. But in this case, the interesting thing is, unlike 5-FC, these agents are active against all species of Aspergillus, even the one that's resistant to amphotericin. And so I'm keeping an eye on this. I'm hoping this might emerge as the next class of effective systemic antifungal drugs. And I think the final set of slides, and we'll definitely finish on time, discusses terbinafine, which is only available as an oral preparation. It is a synthetic allyl amine. Inhibits squalene epoxidase, which is also on the ergosterol synthesis pathway. And most of us in the room know this drug. The way we know it is the fact that it's active against dermatophytes and against onychomycosis. It also is active against the agents of chromoblastomycosis, and our VA patient who has that infection has taken lots and lots of terbinafine through the years. Its major toxicity is hepatotoxicity. Doesn't have that many drug interactions, but rifampin is a major one. Rifampin actually increases the clearance of the antifungal. And that looks like I'm done now, and I'm ready to ask for questions or clarification. So thanks for coming. Could I entertain any questions? Hi.
The difficulties that we encounter is in the identification of the fungus.
Right.
What is the reliability of microscopy versus culture? And then when it is resistant to, according to the book, where do we get the sensitivity testing?
Okay, thank you. A couple of different questions here. One, what are the best modalities for identifying the causative fungus? One could be just microscopy, looking at a direct smear of sputum, for example, versus culture being worked up in the mycology lab, versus even potentially a PCR or a serological test. And this is one area where the clinical mycologists' eyes in the lab are still extremely useful. And what I might mean by this is that, including in this hospital, when the mycology lab tech knows that they're looking for a fungus, they're going to, first of all, look at a direct smear and maybe get a clue as to the fungal diagnosis that way, because there are distinctive forms of each fungus that grow in a human that sometimes can be unique, other times not so unique. So one example of not so unique would be Aspergillus looks just like Pseudalischeria in the sputum. So at that point, after they've done the direct exam, then they will set up cultures at 2 different temperatures. And with any luck, the bug will grow. And for that example that I'm giving of Aspergillus versus Pseudalischeria, whether the culture is planted at 30 or 37 degrees, they're both going to grow as fuzzy bulbs on a culture plate. But now the sporulating structures that they could examine under the microscope are not going to look identical. So at that point, they're going to start to differentiate between Aspergillus and Pseudalischeria. And we could give some other examples like that. So in a case like that, there actually wouldn't be a need to go to expensive molecular biology type techniques to make the differentiation, because we know already. Now, good question. Where do we go for antifungal sensitivity testing? I know we're not doing it in-house at the VA, and I doubt if any is being done in-house now, although the last time I checked into it, I knew that Jerry, the previous chief of the micro lab, was interested in a kit that was like a microtiter kit where you could titrate various antifungal agents against known inoculi of, for example, Candida in microtiter wells. But if that's still not in place here as something you can order clinically, then the answer is they're going to get sent out, and some of the better reference labs would include the Mayo Clinic, which is where we send ours at the VA. It's rare for us to feel a need to do initial upfront antifungal susceptibility testing, because the majority of our cases hopefully will respond to whatever empiric antifungal therapy we choose. But certainly in evolving failures, those would be examples where we would have to know antifungal susceptibilities. And I think one very good point, I don't know if you're trying to make this point, is that delay could be harmful to a patient.
How long it will take from the time giving the sample to do this?
Yeah, I mean, you'd have to first grow the bug and then ship it to wherever you're going to ship it. Mayo Clinic, it's going to be 10 days or 2 weeks. It's not going to be like getting an antibacterial MIC back in 1 or 2 days. Fortunately, most fungal infections don't move that quickly, but some of them could. Invasive mucormycosis or aspergillosis in a neutropenic patient would be a great example. So I guess we're still in the dark ages in the sense that we don't have relatively inexpensive kits that we can bring in-house and get this job done where the rubber meets the road. Any other questions? Okay, thanks again.